I don't know if the last time you drove in a car that did not have a backup camera, but if your car has a backup camera, you probably have gotten used to it starting to beep loudly at you if you're about to back up and hit something. And then if you've been doing that for years and you get into a car without a backup camera, you might just back up and wait for the beeps and not realize those beeps aren't going to come. You have been de-skilled in your backup skills. And so the question is, if learners are relying on AI to do things for them, are they going to de-skill, or might they be never skill in the first place?
Hello and welcome to AI in Healthcare. I'm Mika Newton, your host, and I'm super excited to be here today with a friend and colleague who I've known for quite a little bit, Dr. Ben Rosner. Ben, great to see you, as always.
Hi, Mika. It's great to be here.
Great. So, you and I know each other, but maybe just for our audience, could you give us the quick 1 minute on who you are and things that you've been working on?
Sure. So I am a hospitalist at the University of California in San Francisco. A hospitalist is kind of like a primary care doctor just in the hospital. But I'm also a PhD researcher, and I do research on digital health, artificial intelligence, how digital health companies integrate into electronic health records. And my background has always been at the interface between technology and medicine, looking at how we can kind of apply technology to make what was initially the triple aim, then became the quadruple aim, and then the quintuple aim of healthcare better. But this is over about improving healthcare for patients, for healthcare providers, for the system in general.
Awesome. And we're going to have a lot to talk about. So I was just reflecting back, thinking about this conversation from earlier. You and I worked what must be 15 years ago together. And so I thought one of the interesting things we could kind of do is a little bit of the then and now and maybe what's next sort of perspective from ourselves. So over the time, I think as you reflect back over kind of the last decade or so, and then maybe bringing it into the context of some of the projects you've been working on, where do you think we're going in the context of AI use in hospital system? Because it's a buzz, right? Everyone's talking about it. And a big question I have is it really happening? Is it something that was anticipated and thought about for a long time and is now something that people are ready for? Is it a brand new thing that people just started thinking about and are going to implement in the future? So kind of where are we from your perspective in the implementation of AI in hospital systems?
Yeah, so I think when we think about how technology is influencing care, there have been a couple of major milestones or events that I think were really big ones. So Mika, back when you and I initially worked together, it wasn't long after the electronic health record became this new thing. And I trained in medical school in the day when they were paper charts. And the transition to the electronic health record itself was a massive change, that was meant to drive improvements in care, cost reduction, all that stuff. Whether or not it achieved those, that's a separate question. But it was a fundamental change in the way we practice medicine. And it's not very often that we encounter those sorts of things. But I will say, generative artificial intelligence, which is a special kind of artificial intelligence, does feel like a seed change in the way medicine will be practiced in the future. We are really just at the beginning, but it's a massive change that we are already seeing electronic health record vendors pivot in a big way to accommodate, and most health systems trying to figure out what they're going to use and how they're going to use it and how they're going to monitor the use of these kinds of tools.
So as you think about that and evaluating them, and I want to come to a project that I know that you've worked on here, is it about finding the specific utility? Is it about its integration into the platform itself? What are the kind of levers as a health system is thinking about it that you're trying to balance? Safety, security, we've spent a lot of time talking about that. Biases. Is it access to the EMR? Does it have to be part of the EMR that you buy, or could it be a third party? I think a lot of these things seem, complex at best.
The use cases are innumerable, and they range everywhere from the totally not sexy, administrative use cases, to help with back office types of things, whether it's billing and coding and revenue cycle management, to the sexier stuff that is sort of more clinician and patient facing. And so there are all kinds of use cases too for like even how do we train medical students and residents, and what are good use cases for their learning. And so these are possible both with tools that are not inherently part of the electronic health record system, as well as tools that are deeply embedded into the system that are third-party vendor tools, but as well as the electronic health record vendors themselves who are rolling out baked in generative AI capabilities, and even in some cases that are AI native electronic health systems. So it is covering the entire spectrum. And what each health system is choosing to focus on depends a little bit in part on what their pain points are. Revenue will always be a pain point for health systems, but in some cases, from patient safety perspective, maybe that's a pain point in one area, or how to train better, medical students or residents might be a pain point for other health systems. So it's really all over the board. What I will say that's in common is a lot of health systems have created roles called chief health AI officers that did not exist even a couple of years ago. When I was training, chief medical information officer didn't exist, and that's sort of a fairly standard thing now. So chief health AI officers are now becoming widespread, and every health system is going to need to figure out how do you implement these tools and how do you monitor them over time.
Yeah, that's a great point. So just, I guess, a comment though that came to mind, it feels like when the EMR vendors, the Epics, the Oracle Healths of the world, et cetera, are rolling out native built-in Gen AI capabilities, right? We've definitely moved away from the like, does AI even belong in a healthcare debate, which frankly wasn't happening even that long ago, right? Like there was a lot of, well, how do we trust and all the rest of it? But if it's coming out of the box, so to speak, now from the actual core suppliers of the systems themselves, that makes me feels to me like it's here and it's here to stay. The choice between using the out of the box functionality, I assume, in third parties is more about, extra cost spend or value. And so we're going to get some value competition, which is good, I think, and security. Now, I know you worked on a project related to discharge summaries specifically. So that's, one specific thing. Could you kind of describe that project? And maybe that was like a hands-on experience in trying to implement AI for a specific use case, right?
Yeah. So, one of the things that these large language models, like many people have heard of ChatGPT, that they've gotten increasingly good at is summarizing. And summarizing what is in the chart is a relatively lower stakes type of function than, for example, asking the large language model to help make a diagnosis or to help with treatment decisions. Those are higher stake things. But the idea of chart summarization also sort of followed on the heels of one of the early types of rollouts, which is, a lot of primary care physicians, they have email inboxes and they are inundated with emails. And so several health systems kind of rolled out automated draft responses that were generated by large language models. They were fairly good at sort of looking at the question the patient emailed in, looking through the chart, and then drafting a response that the physician then could edit before sending. And on the heels of that, I'm a hospitalist, and so one of the big tasks a hospitalist has to do before a patient gets discharged from the hospital is to write what's called a hospital discharge summary. This is supposed to summarize like all the clinically important events that happened and some of the follow-up needs. And these summaries typically get sent to the primary care physician, or if the patient is going to a skilled nursing facility after hospitalization, it gets sent to that physician. But the challenge with writing these discharge summaries is that to write a high quality discharge summary requires the hospital physician to look through that hospitalization. And you can imagine the longer the patient's been in the hospital, the harder it is to write a summary of all the important things that happened. And for those in your audience who don't know, most often when patients are hospitalized, they are not cared for just by one hospital physician who has been with them for their entire hospitalization, who might sort of have in their head, here's all the things that happened. So, for example, I think I had a few months ago, I came onto service. It was my second day on service, and there was a patient who had been in the hospital for more than 3 months, and they were getting ready to discharge. And so I am tasked with, I have got to summarize the last 3 months. I've only known the patient for 2 days. And so to generate a good quality discharge summary, I'd have to take an hour and a half of my time and start what we call chart biopsying, looking through the notes throughout the hospitalization and then starting to compose this summary. Well, that's burdensome. It's called documentation burden, but it also takes an hour and a half of my time when I could be seeing other patients to just write this thing. And so the question we asked is, well, can these large language models look through the entire hospitalization and write a decent, high quality, safe draft of the summary that then the physician can go in and edit and then sign and send? And so we did a study to look at the quality and the potential for harm that these large language model drafted discharge summaries these large language models could draft for discharge summaries.
Interesting. Is there a standard? So I think anytime I hear of kind of a study of saying like, hey, did the model do a good job? Like, what do you compare it to? Is it just what you as a clinician feel is a good discharge summary? Is there a standard format or form, or, what should be included in the discharge summary versus what's trivial? Does that vary? Like what's the comparator?
Yeah. First of all, what should be included in a discharge summary? There are some standards for that, and a lot of those can get automatically pulled into the discharge summary, like the medication list and the discharge diagnosis. The part that's really time consuming to write is this narrative, like here's what happened. There are some emerging standards. One is called a PDSQI-9. There's one called a 4Cs. These are some metrics that have been developed about like what consists or what should be present for a good summary. But I will say many of them are similar in that, the summary should be coherent, meaning that
That'd be good.
the flow should be like, it should make sense. It should be logical, but it also should be concise. You don't want a discharge summary that rambles on indefinitely. It should be, free of errors. We have heard of the term like hallucination. That's just one error type. But there are other error types. There are inaccuracies. There's omissions. And so there's a handful of these dimensions. In our study, we also added, if you're looking at the errors, what is the potential for harm that each error could cause? Because just counting errors is not super helpful. You want to know like how likely is that error to maybe cause death versus maybe just cause some emotional harm or whatever. So we actually quantified also the potential for error of each harm. And then like in our study, we actually asked our human reviewers, when they were blinded as to who wrote the summary, was it a physician or was it the large language model? Which one of these do you prefer? And what is your ranking of the overall quality of these things? So those are some of the metrics we used, and they're pretty similar to metrics that a bunch of others are using for similar things.
So who wins wins is probably the wrong word, but I guess the real question is, can you use LLMs to reduce the document burden for discharge summaries? Is it ready to go? And like, what should we worry about? I really like the fact that you looked at harms, because the question, I assume, depends on what kind of discharge is it and how sick was the patient and were they there for 3 months or 1 day? And it seems like there's a pretty broad spread there.
Yeah, well, to answer your first question, are we there yet? Are they ready to go? The answer seems like a yes. I will explain some of the details of our study, but in many ways they were equivalent. The human and the LLM written discharge summary. We've seen other papers come out after ours too. Ours was published in JAMA Internal Medicine. There was another nice paper out of NYU that was published in JAMA Network Open. And not only do these studies seem like, yes, we're ready to start piloting these for real, but also we see the electronic health record vendors actually making this capability now. They're rolling it out actively right now, making this capability available. Now, doing this with real patients, is a different thing than doing it on sort of historical charts. And so health systems that do plan to deploy these things need to think about how are they going to evaluate these pilots? How are they going to do it safely? But the goal is, yes, to decrease the documentation burden, but also give back time to the physician so they can actually do patient care as opposed to just doing documentation. The thing that's pretty interesting, the way we did our study, is we actually took some 100 charts of patients that were in the hospital that had already happened. These are de-identified charts, so there's no patient identifiers. We then removed the discharge summary that the physician wrote. So now we have this corpus of hospital notes. We fed those notes to the large language model and said, generate a discharge summary. Then we had this physician-written discharge summary that we had removed. We had the LLM-written discharge summary, and we asked an army of human physician reviewers to look at the physician-written discharge summary and compare it to the hospital notes. So we used all those hospital notes as the gold standard. And we also asked them to look at this LLM summary compared to the hospital notes. We asked them for errors, including hallucinations. Here's what's interesting. Even the human physicians hallucinated, and the human physicians made errors. So a lot of people think, well, can the large language models be error-free? And I'd say that's the wrong benchmark to compare them to, because the human physicians are not error-free. They're not even hallucination-free. And so really what we were looking at is, are they comparable or better than the current level of care, which is the human physician note? And for the most part, we found they were. We did find, for example, that the large language models made per discharge summary, they made more errors, but those errors had very low potential for harm. And overall, our reviewers had equal preference for the large language model summary versus the human summary. They found large language model summaries were more concise and more coherent than the humans. So for the most part, they were fairly equivalent. That doesn't mean that when these things get rolled out in real practice, we don't need to be diligent about looking at these potentials for harm, errors, etc. And that if I use the tools to generate one, I need to make sure still to read that draft. There is always the risk of this thing called de-skilling or cognitive laziness, which is to say, I trust the large language model enough that I'm just going to sign it. And that we have to be really careful about, because we do need to carefully read these things and then correct errors and make edits before we sign them.
Yeah, I learned that the hard way with having AI write my emails. You might want to read them first, right, before you send them. Otherwise, things get strange very quickly. Sorry, bad joke. It's interesting as I think about that. So one of the things, I've been working on, right, and companies have been working on, is actually reading medical records. And we're using AI to read medical records. And I think many of the large EHR vendors are actually rolling out this kind of in-record summarization. And then those records are eventually going to be potentially passed to another hospital, a patient, particularly one who might have chronic diseases, right, or may have several things wrong with them, may not just go to one system. They might actually travel between systems and move from one system to another. And so I always think about, like, how soon are we going to get to the point where the AI is reading what the AI wrote, right? And do these errors then start to propagate, right? So if you introduce an error, and where I've seen this before, like working with cancer patients in particular, we see this pretty often, is the progress notes, right, are simply cut. There's this like cut and paste and cut and paste. And whoever the next person is who's coming along or for the next visit, the entire note or summary of the previous visit is cut and pasted, and then something is changed or added to it in the top part. And when you go back and you start looking for the errors, you find the error was made, a year ago or 2 years ago, but it's now been repeated so many times that if somebody didn't go back all the way to the very beginning and say, why did this happen? Right. You would never assume. It's not even in the last one. It's in 200 rows down, basically, in the field. Is that something that gets talked about? Is that or anticipated as we start rolling this sort of stuff out?
Yeah, the idea of error propagation is super important. That's a great use case or example. I will say that, we're in such early days with the rollout and use of these tools that I don't think people are thinking that far ahead. But it is an important consideration. I mean, theoretically, the exact same thing can happen with a human too, right? Like a human introduces a hallucination or an error, and that simply gets propagated. I don't even know actually the degree to which, if that has been studied, to the degree to which that already happens, but I'm sure it does. And so it's another thing that should be added to the table of like monitoring. Like, how can we monitor these things, and then can we catch them and correct them?
Well, the example I gave you was a human, and I've seen it. Seen it many, many, many times over again, where the same thing were initial errors. It actually makes me wonder if there's a study to be done about using AI to find the errors, right? And if we don't have to introduce kind of the safeguard systems on the other side of the coin, which says we know that we're generating a lot of information and data here, have this other model go and check on our generating model and go and find places where you think it might have made a mistake, right? And that we're going to need some sort of error correction in there. We probably need it for the humans as much as we need it for any AI that's trying to replicate one of our tasks.
Yeah, well, I mean, what you're describing, if you don't know, there's already a term for it, which is LLM as a judge. So one model generates some output and you have another model assess that output for errors. But there's even a arguably better approach. And this is just emerging. And in fact, it's something that I have a study just getting underway on right now, which is LLM as a jury. And so a LLM as a judge is just one LLM judging the output of an initial LLM. But LLM as a jury is, imagine you put several different models all into the same room together and you say, duke it out with each other and come to consensus. Like, we want you to evaluate the output of the initial LLM. And now there's 3 of you in the room, duke it out, come to consensus. And so we are trying to take a look at, can LLMs as a jury be just as good or maybe even better at detecting errors than humans? And here's the interesting thing. In this paper that we published, we had 22 physicians reviewing all of these discharge summaries, and it was a massive effort. And that does not, and it will not scale. And so imagine like a health system, they implement some generative AI tool, and then, I don't know, 5-6 months later, the tool gets updated and you've moved on to the next model. There's no way to scale that army of people again to go through the entire thing all over again. And so we really need to think about more scalable ways to monitor and assess the quality of the outputs. So LLM as a jury is still sort of emerging, but it'll be interesting to see whether they can do a better job, or at least maybe to get us 90% of the way and then leave the last 10% for humans.
Yeah, that's a really interesting. So first of all, I'm very interested to hear about the outcome of LLM as a jury. It reminds me of a discussion that we had actually with the FDA earlier. We were talking about software as a medical device many years ago, and we were very interested in developing medical devices in which the algorithms would evolve over time. So as continuous learning, right, as part of the algorithm, well, that gets hairy pretty quickly, right? If you're going to have an approved medical device where you need to understand the performance characteristics of it, and if it learns from every interaction with every patient, which is probably closer to the way human beings learn, right? I would assume that physicians are learning from every interaction or trying to and developing better skills. How do you know when it's going wrong or going better? And we were trying to develop a mechanism to essentially put continuous improvement or put performance bounds around the outputs of the model. So you would know that there was some threshold that if you crossed it in some particular direction, that it was time to break out the human jury again. It was like, when did you need to notice that difference? And so we thought about performance characteristics. The other thing that we spent a bunch of time thinking about was, could you actually just run the models simultaneously? So if you have these competing models, which is what you're reminding me of, it's the jury question. How far apart do they need to be where you say, wait a minute, there's a true, like, what's the disagreement level, right? At which point you say, you know what, I actually don't want you to come to consensus. I've got to check again because, you say it's red, you say it's black, right? And it's definitely probably one or the other and not some sort of, dark purple in the middle. So how do we do that sort of thing? So I'm actually fascinated to hear that works out, because I also couldn't imagine how you can validate this type of work at scale, especially if we implement AI throughout the workflow processes of these hospital systems. So really cool. Cool. I have another different line of question here. I've been thinking a fair bit about AI in medical education, and actually medical education in terms, I think, of both educating and learn. I use AI to do research, right? And then I try to accept, or I get the results. Sometimes I believe it, sometimes I don't. Sometimes I go double check it. There's been a fair amount of discussion lately about people just believing the AI, no matter what it says, and not going to validate it. It's kind of cognitive laziness. There's a whole thing about AI psychosis, where I guess people have convinced themselves that the AI is telling them the truth, and it tells them things that are completely untrue about themselves. Um, are we going to get to a place where we can trust the generative AI with the basic education or learning that you need to go through as a physician? That's what I think of, like medical education. How am I learning from the AI? Is it summarizing things correctly? It, is that an area where this will also work outside of the hospital environment?
Yeah, I mean, one of my roles at UCSF is I'm also the faculty lead for AI innovations in medical education for the School of Medicine. And these are some of the very things the very questions we're struggling with ourselves. There are some, kind of low stakes use cases for AI in medical education and some higher stakes ones. So some of the lower stakes ones, again, not super sexy, but here's an example. Medical students, residents, they have historically needed to keep some kind of logs of the types of cases they've seen or the procedures they've done. It used to be you'd keep literally a paper log. I just did procedure X and I got here's the date I did it. And, that eventually moved to some other electronic platform, but you'd still have to go and type it out. And so, people are, especially when they're training and in practice, there's not a whole lot of time to go and sit down and type those things out. And so the question is, can we just use AI, generative AI, to read through the chart and say, okay, this procedure was done, and it creates the log or the case mix log to make sure that the students are getting the appropriate exposures and training they need. That's pretty low stakes, not super exciting. But I will say there are all kinds of other use cases, both in learning for medical students before they start seeing patients, like in the first 2 years or so of medical school, and in their last couple of years when they're seeing patients. And I will say whether we like it or not, the students are leading us where the future is going to be. They are all already using AI in some way. And so it really becomes incumbent upon us as the educators to figure out how do we put some reasonable safeguards in place and guardrails and make sure that they're using these things in responsible ways. One of the interesting use cases that's somewhat administrative but is also helpful for teaching is to try to figure out from like notes, let's say a medical student has written, and ascertain, can we determine what their clinical reasoning process is? Now, historically, that would be very time intensive. You'd have a attending physician look over the note that a student wrote and then sit down with them and say, okay, from this note, here's what it looks like your clinical reasoning is, and here's some of the opportunities, some of the challenges. But could we have AI do that assessment on each and every note and then maybe generate what we call tutor bots, so like an AI generated case to help with certain areas that were weaknesses, to help teach that learner in a scalable way. And so those types of things are also coming too. But what I will say, and this is an area of particular interest and concern, is this thing called de-skilling. And so what I mean by that is, I don't know if the last time you drove in a car that did not have a backup camera, but if your car has a backup camera, you probably have gotten used to it starting to beep loudly at you if you're about to back up and hit something. And then if you've been doing that for years and you get into a car without a backup camera, you might just back up and wait for the beeps and not realize those beeps aren't going to come. You have been de-skilled in your backup skills. And so the question is, if learners are relying on AI to do things for them, are they going to de-skill, or might they be never skill in the first place? And there was a study that came out just like a week ago about the use of videography-assisted AI in colonoscopies with gastrointestinal physicians who have been doing colonoscopies for years, having 3 months of usage of AI-assisted colonoscopy, where on the screen the AI is detecting polyps. And after 3 months of using AI, they were then exposed to either not AI or with AI colonoscopies. And it found that these physicians who have been doing this for decades de-skilled, they had become so reliant on the AI that when they were not using the AI-assisted colonoscopy, they were detecting fewer polyps than when they were using it. So it's a real concern, and medical educators are thinking a lot through how do we make sure that not only are the skills developed in the first place, but that once AI tools are used, that we don't lose these skills.
It's interesting. I actually spent some time talking to a company in that very specific space of using imaging for uh, for assisting with colonoscopies, and they were showing me how um, basically on the video screen it would highlight what was the polyp, and it would tell you whether it was cancer or not. It had a whole bunch of metrics on the back end, and a big part of the value proposition and argument is like the first colonoscopy of the day when you're feeling fresh and you had your coffee in the morning is a lot better than the last colonoscopy of the day when you're tired and you want to just go home, and that this would introduce new standards and a better and higher standard throughout the process. And based on what you're saying, it sounds like the people who are taking advantage of that text may actually be de-skilling themselves. So it makes me wonder, is that a bad thing or a good? Like, how do we judge that, right? If it's better with AI, but that makes the humans a little bit less good, but it's still better with AI, is that still okay? Or is it bad that the humans got less good at what they were doing in the first place because they got the assist?
Well, let me ask you this. Like if you were to get on an airplane and there's AI somehow assisting the pilot and now it makes travel safer, but let's say the systems go down. Do you want your pilot de-skilled? So, I'd say the same thing like in medicine. These are sometimes life and death type of activities and decisions. And so maintaining skills, establishing them in the first place and maintaining them, I would argue, is probably super important, even though when everything is going right with these tools, they may, in fact, make us better. And so some health systems, especially, where trainees are learning, are thinking about, well, maybe in the first year of training as residents, we don't let them use any AI tool because they have got to develop these skills in the first place. And then only turning on the availability of some of these AI tools when they're perhaps in their second year of residency. But I don't think that there is a standard yet, and different health systems have different tolerance for when they make these tools available.
When you started talking about the plane, it made me think of, if the AI makes the plane safer, I definitely want the AI helping the pilot fly it. But I also want that pilot to go in a simulator when I'm not on the plane and do some flights without any AI on a regular basis, just in case the co-pilot doesn't work out. One of the other areas in medical education, you and I both spent some time in this space. I was thinking recently about evidence-based guidelines, right? And the practice of care. And the fact that the longer we seem to go, the more guidelines people seem to come up with. And the guidelines change pretty frequently. And the volume of medical knowledge continues to just like mushroom cloud. It is just to the point where I do not believe that anybody is consuming even a fraction of the amount of information and new data that's coming out. And so, in some ways, the best practices lag the knowledge. That may be okay because we want to harden the knowledge. But even when we get to the best practices groups, just thinking of all the medical societies are all publishing guidelines at different times, some of which conflict with each other. Many times we have multiple societies who feel that they have, authority over often the same area. Is there any thought about education and the hospital systems about their own protocols and best practice? I'm assuming a provider system has to decide based on their own clinical insights and their own clinical expertise, what they believe is the right standard of care for them to exercise in the hospital. Is that an opportunity for education as well?
Yeah, I think so. And you're right about the volume of medical knowledge. There's no way for any individual to stay on top of all of it. I'll say larger health systems benefit by having committees which are meant to try to stay on top of guidelines and decide what they're going to implement or things of that sort. But those are the exception to the rule. There are plenty of small health systems, rural health systems where those resources aren't available. And so, Can AI potentially help guide the clinician to the latest practice guidelines? Yes, absolutely. And in fact, I have a project right now where we're looking at trying to help physicians adhere to best practice guidelines, because again, there's the volume of information and knowledge is so massive, it's impossible for people to stay on top of.
That was actually where I was going in my head. I was wondering if you could look at the episode of care. So, and maybe I'm phrased the wrong way, but if you look at a patient's care journey, whether it be through one institution or one encounter or not, could you actually find all the places that care deviated from this, what's considered the best practice standard of care, and use that as a learning mechanism? And there's lots of reasons, right, why you don't do exactly the same thing. My wife works in a hospital, and she'll always tell me that, like, you have no idea what's going to happen next, right? I assume you have the same experience. And sometimes you have to call whatever you're going to do just based on whatever happens, and then you need to figure out how to, remedy the situation. Certainly, that's individual, right, in the situation itself. But is that an idea of actually looking at overall quality and content of care and then creating, is that an education opportunity then?
Yes. So part of what I work on is called diagnostic excellence, and that's looking at, how can we help clinicians continuously improve in their diagnostic performance. And the analogy I think of is like, if you are a professional football player, you can bet that after last Sunday's game, you are reviewing the footage and learning from what you did well, what you didn't do well, to improve your next game. And you see that over and over again. You see it in almost every industry and not in healthcare. Why is that? Well, it's hard to know, especially for diagnosis. Like, did you get a diagnosis right or not? There isn't necessarily always a gold standard, but even when there isn't like a system in place. There aren't dashboards in place to say, hey, Dr. Rosner, you got, 84 of those diagnoses correct, but then there's 16 you didn't. And these are the ones that you need to learn from to get better. I'm actually working with several medical specialty societies right now that are actually building dashboards looking at clinician adherence to diagnostic practice guidelines. So what those mean is, like, if you're diagnosing X, Y, and Z, are you doing all the right steps necessary to get to the diagnosis? And the idea being, the physicians hopefully then learn from opportunities to get better as diagnosticians. It's called recalibrating. But one of the challenges in medicine is, if anybody ever comes up to me and says, hey, Dr. Rosner, do you remember that patient from 2 weeks ago? The moment they stop there, all of a sudden I'm like, oh no, did something go wrong? Did I do something wrong? So there's a culture in medicine of not, of not wanting to be told that something didn't go right. And we need to really change that culture, because at the end of the day, clinicians are humans. And there was a major publication years ago called To Err is Human, and clinicians will err, but we have to learn from those errors. And so creating a better culture in medicine to say, here's learning opportunity, just like other industries, you want to learn from it so you get better. And then creating also space and time for clinicians to look at those errors. Right now, our time is filled with patient encounters, and there isn't time set aside to say, hey, you should look at your performance metrics so that you can learn how to get better.
Is there a liability concern? Is there like an institutional, hey, we don't necessarily want to pinpoint all of the places we deviated because those might be things where we were, does that, so I'm just picturing the lawyers in the room, always spend enough time with them. Is that a thing that people worry about?
It possibly could be. And I'm not a healthcare lawyer, so I can't exactly speak to that. But I do think that there is sort of that lurking in the background. But frankly, I don't think that burying our heads in the sand and saying, I don't want to learn from past experience, to me, that just doesn't feel like the right approach. I mean, I think the right approach still has to be, we are humans, we are not perfect, but we should do everything we can to learn from past performance.
I 100% agree. I've actually spent some time, I was pondering this a little bit, is actually benchmarking. So one of the questions that ran into, we're doing some direct-to-consumer healthcare kind of decision-making, is where do I go to get this procedure, right? And who should I see? And I mean, I think I struggle with this, right? I have something, I want to go see a doctor. I can go see one of this list of 200 people who appear in what look like a phone book. Each one's got maybe some star thing next to it that I kind of vaguely understand. But I know about a very specific question that I have, and I want the expert in that question. How do I know who provides the best care for someone like me? And I realize a really complex question of like, what is someone like me? What is the actual problem, et cetera. But it feels to me, as much as we are trying to benchmark costs, and there's been a lot of discussion about the cost of healthcare and better transparency and the costs and payments between that, we should also be getting to a higher level of transparency, right, about the performance of different healthcare systems, particularly as it relates to the decisions that we're making when we're all kind of shopping for our own healthcare here. So how do I know if I'm making a good decision or not? And it feels to me that this whole benchmarking, education, are you doing the right thing, is kind of fundamental to that question.
So a good question. I think that there are several ways that one might assess who provides the best care for what you want. One is sort of the softer metrics, right? That is sort of like health grades or vitals, where people can post their experience, sort of like Yelp for healthcare, right? People can post their experiences or rate their doctor. That's one level of assessment. Then there are things like harder metrics, like if you're thinking about having a surgery, what is the surgical site infection rate of Doctor 1 versus Doctor 2? There have been some efforts in the past to try to make those data more transparent. They were used with like Medicare data. So for older patients, there was a site called hospitalcompare.gov, which I think may not be functioning anymore.
I think I saw it. I think it might be up, or it was up recently, I think.
Okay.
Yeah.
But I will say, as a country, we don't do a great job with making those data more transparent, because we're a very fractured health system. We have lots of different payers, lots of different health systems. So in countries where there's a single payer, for example, it's much easier to say, here are the performances of different physicians. So the closest we can come to that is with some of the CMS data. But again, that's mainly for like our older populations. And if you're a younger person, you may have different comorbidities than an older patient, and the metrics may not apply to you as much.
Yeah. Yeah, I was just interested when you were talking about the individual performance of physicians as related to guidelines. It automatically took me almost in my mind to the system level performance, right? Like, so if I want to go, should I be going to Kaiser or UCSF or Stanford or John Muir for one particular type of care? And they will all, if I go and talk to them, tell me how great they are, right, about each one of the things that I want to go to, but there must be performance characteristics, and maybe actually depend on who I am, how far I'm willing to travel, a lot of the soft metrics that are interesting. Well, let's move on. One of the things you've been working on really is understanding API and API standards across the EHR systems in healthcare. I know it's a project I think you've been working on for a while, if I understand it correctly. Can you tell us a little bit about that?
Sure. Yeah. API stands for Application Programming Interface, but that's technical language for how does one computer or a computer program talk to another one, and in essence speak the same language so they can pass information back and forth. So one of the things that that has happened in the last 15, 20 years, as like consumer technology became more prevalent, people are very used to, let's say, opening up an app on their phone and ordering something from, a food delivery service. Just very easy to transfer. Here's some information I want to send, and then I get a service delivered back. So in the consumer world, digital technology is frictionless. But in healthcare, there's been a lot of friction, and in part, how can information be shared between, let's say, a patient or, let's say, a digital health vendor, a company that offers digital health solutions, and the electronic health record, which is sort of the work environment and almost like the source of truth for everything that goes on in the healthcare setting. So if you're, for example, a company that's developed some tool that helps patients monitor their glucose or their step count or anything relating to health, and you want that data to flow either into or from the electronic health record, you have to use these APIs to get the data to flow. A lot of people don't think about this, but this is like all the pipes that are inside the walls of a building. You don't usually think about it. You just go to the faucet and you turn it on and water flows. But connecting all the pipes takes a lot of work. And it's not always easy to do. And so we actually did a survey of digital health companies in late 2022, but we published it last year about their experiences with using what are called standards-based APIs to connect or integrate with these commercial electronic health records. And the reason we were interested is that the federal government, at the time it was called the ONC, the Office of the National Coordinator, had put out policies about commercial electronic health vendors should make standards-based APIs available. They were mandated to, so that it was easier for these companies to integrate into electronic health record. But nobody had any idea, did these standards work? What were the companies' experiences when these things were supposedly turned on? So we did a national survey to try to understand it. And we found that a lot of companies, while they were using standards-based APIs, the ones that sort of we want to make so that it's easier to integrate, a lot of them were still using these proprietary APIs because for some reason or other, they had to do both. And when they were using APIs, there were still lots of barriers, like high cost, difficulty finding what are called API endpoints, like where do we send or extract the data from, and things of those sorts. So it's been a couple years since that survey, and we're actually gearing up to do another one that we will be launching this winter to see, has the needle moved on federal policy and trying to make it easier for these companies to integrate into the electronic health record.
Well, you probably saw a couple of weeks ago the big push from CMS, right, with the different networks pledging to support. And a big part of that initiative is actually to make healthcare data available. I'm particularly excited myself to see individual access services, or an ability for individuals, right, like myself, to authorize another application to access my health record and actually be able to find that. Because I think for far too long, people have been trying to get their medical records all in one place, just as individuals, like particularly if I have a complex or rare disease. And we see, people walking around with banker's boxes full of paper records still, and printouts from different things. And that's just not how we should do things in a modern digital age. But I don't think we've had the technology, or even if we had the technology, we didn't have the governance systems really to establish who had to share what with whom and why and where and in what standard form. And so even if we all agreed it was a good idea, we didn't have an agreed method for this exchange. So I'm pretty excited. What was the results of the first survey? You said it was that people were still kind of running standards, but then they had their own proprietary APIs. Was there a sense that things were moving towards more standardization, or was it still a very fractured field?
Yeah, it was pretty fractured. And, the timing of that first survey just happened to be just months after the mandate from something called the 21st Century Cures Act went into effect. So we probably would not have seen a whole lot of effect yet, because the deadline for these commercial electronic health record vendors to implement these things was right upon us as that survey went out. So in a way, that survey sort of set a baseline, and the survey we're about to launch this winter will actually show us, has the needle moved at all since the 21st Century Cures Act mandates went into effect? And then where might we need to focus future policy attention to help continue to take the friction out of the system?
Yeah, totally agree. So tell us about, you're running the new survey now. If someone felt like it was something they wanted to participate in or they were interested in, how would they get involved? Is this something that other groups and companies can get involved in?
Yeah, we actually have a pre-registration website. These are intended for digital health companies that integrate into electronic health record. We plan to probably disseminate that survey in the winter of 2025-26.
Got it. Wonderful. Well, thank you so much, Ben. It was awesome having you on the show. It's always great to talk to you. I learned so much every time I speak with you, so this is really great. Thank you so much.
Thank you too, Mika. I enjoyed it.